after this panel discussion, next talk is by me only. So, now we are going to. I'm going to speak on recent abstract of clinical application GA in lung cancer. So, so I will be going through the 4 abstract. One abstract is about, again, extensive stage small cell lung cancer, which we were discussing just now. So newer drug about that. And the second abstract will be about a neoadjuvant setting in the lung cancer, that is NeoScore trial. And third abstract will be about pembro in the adjuvant setting for lung cancer, that is Pearl trial. And last, 4th one will be about the radiation in the small cell. So which dose, because that is also not clearly defined in literature. So all these 4 abstracts I am going to present one by one. Just a minute. Yeah. So my first abstract is Skyscraper II. So primary results of phase 3 randomized double-blind placebo-controlled study of atezolizumab plus carbo plus etoposide, with or without. This is a new drug, that is Tyra. That is short form is Tyra. Tyrogolumab. So in patient with untreated extensive stage small cell lung cancer. So as of now, we all know that atezolizumab is the standard of care with etopo and carboplatin. So this is a newer add-on therapy which was tried in this phase 3 Skyscraper 2. And we have discussed IM Power 133 trial in previous discussion. So TISIT is the newer novel inhibitory immune checkpoint, which is present on immune cells in many cancers, including small cell lung cancer. So it is highly correlated with PD-L1 expression. So Tyrogolumab is a human anti-TISIT monoclonal antibody that may synergize with other immunotherapies such as atezolizumab or so to amplify the anti-tumor response. With this hypothesis, this study was done. And so this is a study where they have included the patient first-line extensive stage small cell lung cancer with no prior systemic treatment for extensive stage, and patients with treated or untreated asymptomatic brain metastases were considered. So roughly 500 patients were taken into this trial, and 1:1 randomization with the experimental drug, that is Tyra, along with these 3 drugs. So 4 drugs were in one arm, 3 drugs in other arm. And after induction of 4 cycles, then maintenance of both arms were received, Tyra plus atezo versus only atezo. And patients were treated until progression and or loss of clinical benefit or unacceptable toxicity profile was there. So there was some endpoint, co-primary endpoint, primary analysis where there was without any brain metastasis. So full analysis set they have taken considered into the brain mets also. So this is the demographic profile in both arms. Age, male, racial status was well balanced in both arms, and brain metastasis were also considered about 6% in both arms, and they were well balanced. Although PFS in primary analysis set where brain mets were not considered into analysis, so we can see the curve and median PFS is 5.4 in the experimental drug, 5.6 in the placebo. There's no difference found. And the same was the story with the interim OS. No difference in this outcome. Even in the full analysis set where they have taken into the account all the brain metastases treated or untreated, even there also there was no difference found in the PFS or OS. Curves were almost overlapping. And if you see the subgroup analysis, so all the differentiating point, if you see brain mets treated or untreated, so bar we are seeing it is on the center line. So it's not favoring any of the treatment modality. So this is also unremarkable. So for brain metastasis also subgroup analysis, median OS 11.7 with the Tyra combination, 10.6 with the placebo one. So this is almost similar. Objective response rate also was slightly higher in the Tyra. CR rate was also higher little bit, but not good significant number. And if we talk about the adverse event profile, so grade 3 or 4 adverse event were seen in both 64%. I think 60, yeah. And serious adverse event was seen in 43 in both arms. So they were also similar in both arms. And although anemia, neutropenia, and constipation was slightly more in the Tyra arm. So conclusion of this study was that addition of Tyra to this triple drug, they did not provide any further benefit over this triple drug combination in untreated extensive stage small cell lung cancer. And although it was well tolerated, but response was not seen in a positive direction. So this study, Skyscraper II, will continue to the planned primary OS analysis and biomarker analysis are ongoing. Based on these data, targeting TILZIT in this scenario at least doesn't appear to be therapeutically relevant. Although in other malignancies like esophageal cancer, I think trials are ongoing and it might be showing positive results at least in non-small cell lung cancer or esophageal cancers. So second study was about the neoadjuvant scenario in the resectable non-small cell lung cancer. And here dilemma part was that whether we should give 2 cycle versus 3 cycle of any neoadjuvant drugs. So here they have tried the newer drug, that is sintilimab. Basically, it was the, I think, Chinese study where they have combined sintilimab with the platinum doublet in resectable non-small cell lung cancer. As I said, neoadjuvant immune checkpoint inhibitor plus chemotherapy have shown promising efficacy as a neoadjuvant, no doubt. But a dilemma was that whether to use 2 cycle or 4 cycle before going for surgery. So that was debatable. And this was addressed in this study. So sintilimab is a monoclonal antibody against PD-1, which have shown the favorable MPR, that major pathological response in single agent setting in earlier trial. So after this, that trial was done along with chemotherapy. So before conducting this trial, these were the all studies which have been conducted so far for this scenario, which have shown good MPR, major pathological response up to 60-67%, even 83% with nivolumab plus platinum doublet for 3 cycles in stage 3A. So this was the trial design for this is NEO-SCORE, and it was histologically confirmed stage 1B, 3A, resectable non-small cell lung cancer. All patients were treatment naive and good performance status. So sintilimab, experimental drug, 200 milligram day 1, along with chemo doublet, platinum doublet, 3 weekly interval for 2 cycle, and then sintilimab again for 3 cycle. So idea was just to decide whether 2 cycle is enough or we should go for 3 cycle IO combination with a chemo doublet. So after that, surgery was done within 4 weeks after the last dose, and then obviously adjuvant treatment was done for 1 or 2 cycle, and then maintenance treatment with sintilimab. Primary endpoint was major pathological response rate. Secondary endpoint was PathCR, 2-year DFS rate. And baseline characteristics were well balanced in both arms, whether 2 cycle or 3 cycle. Smoking status was also balanced, roughly around 60% patient was current or former smoker in both arms. And adenocarcinoma were there around 35 to 40%. Squamous were there in although more in number, roughly 55 to 60%. And PDL1 status was there, less than 1 or more than 1. It was also well balanced in both arms. So we can see that 3 cycle have shown more response rate in terms of MPR, 41.4% as compared to 26.9% with the 2 cycles. And although p-value was not significant, so 3 cycle treatment have presented a 4.9% increase in PathCR in comparison to 2 cycle with a p-value of 0.660. And similarly, radiological response was also seen if we see the 2 cycle versus 3 cycle. So there was almost 50% response rate with the 2 cycle and 55% response rate with the 3 cycle. And here p-value was significant, 0.70. And if we see the subgroup analysis, particularly for clinical stage, so we can see that stage 1B to 2B bar is on the central line. On the other hand, stage 3A, it is favoring the 3 cycle. So clearly, all the most of the parameters are favoring the 3 cycle in at least in the slightly advanced, locally advanced stage. So if we see the tumor response by histology, squamous cell, non-squamous. So non-squamous is showing definitely better outcome as compared to squamous carcinoma. So based on PDL1 status, it is also not clearly defined in this study. And surgical outcome, if you see all the variety of surgery, segmentectomy, lobectomy, bilobectomy. So 3 cycle treatment did not increase any surgical risk in any of the scenario or postoperative complications. So 3 cycles chemotherapy as well as IO drug, this was well tolerated with good surgical outcome. So treatment related adverse event also, anemia was there, decreased TLC count, thrombocytopenia. So all these side effects, although more with 3 cycle, but well tolerable in 3 cycle as compared to 2 cycle. So conclusion of this study was that it is the first randomized study to compare the 2 cycle versus 3 cycle in the neoadjuvant setting. So I think 3 cycle neoadjuvant treatment achieved a better, higher MPR rate as compared to 2 cycle and was consistent across most of the subgroup. So MPR rate was impressively higher in the squamous carcinoma as compared to non-squamous. So this data definitely suggests that more cycle, at least 3 cycles should be given before going for surgery. So third abstract which I am going to explain was the PULSE study, and this is about the adjuvant setting of non-small cell lung cancer regarding pembrolizumab versus placebo for completely resected early stage non-small cell lung cancer in subgroup related to surgery, disease burden, and adjuvant chemotherapy use. So eligibility criteria were stage 1B, 2, 3A, and complete surgical resection, and provision of tumor tissue for PD-L1 testing was kept. And so there were 2 arms, 1:1, pembrolizumab, standard dosing 200 milligram 3 weekly, vis-a-vis placebo, 3 weekly was given. So primary endpoint was DFS in overall population and also in TPS more than 50% population. Secondary endpoint was also seen in various different cutoff of TPS. And downside, they have given the various characteristic about the profile, about the pembro versus placebo. So they were well balanced about the smoking pattern, histology pattern, and even stage pattern, and EGFR and ALK translocation also. So if you see the outcome primary results, DFS was, we can see that this curve 18 months rate is 73% as compared to 64. So 10% benefit in the DFS if you see the overall population. But if you see the, as per the PDL1 cutoff, more than 50%. So this difference is not there, almost similar outcome, although curves are separating after that. So there may be benefit later on. So if you see the OS, OS benefit is also not seen in this trial. And various subgroup of surgical setting like bilobectomy, lobectomy, pneumonectomy, all of these settings are showing the response in favor of pembrolizumab as compared to chemotherapy in the adjuvant setting. So if you see that this curve, pembrolizumab is better in the nodal status if it is 0 to 1, but in nodal status 2, that is not showing any advantage over and above the placebo. So conclusion of this trial that it supports the benefit of adjuvant pembrolizumab at least for stage 1B, where tumor size is more than equal to 4 centimeter, or to stage 3A and SCLC following complete resection. And if recommended, then adjuvant chemotherapy can also be considered. So last abstract of my talk is on the radiation, because in small cell lung cancer limited stage, so clearly there is no defined guideline whether we should use the radiation in the OD fractionation or twice a day fractionation. So this was one of the study that is called GB30610, where they tried to compare the quality of life in both scenario and as well as the outcome. So questionnaire in the form of FACT trial was kept, and various other questionnaire was kept to the patients, and at different time points they were analyzed. So 417, roughly 417 patients were taken into consideration. And if you see the results of this trial, demography was although like 45 gray fraction versus 70 gray fraction. In 70 gray, they have given the once a day dosing, and 45 gray, they have given the twice a day. And it was completed in early, although 70 gray was given, I think 6.5 to 7 weeks. So demographic profile was well balanced in both arms. Results, we see that this questionnaire fractal was showing that there was a worsening. There was a less worsening at week 3 in the in the red curve, which is for the 70 gray arm. Although it is crossing over there after 3 weeks, so results are ambiguous, showing that they are worsening less in OD dose at week 3, but greater at later point of time at 12 weeks. So the result of questionnaire was mixed in the earlier analysis and later analysis. So treatment convenience score was seen. So it was very convenient to give in 45 gray, 15%, and 19% in 70 gray. So convenience level was also assessed. So both concluded that both like OD dose or twice a dose of radiation were well tolerated and better quality of life score at 3 weeks, but worse at 12 weeks. So once a day arm was perceived to be less inconvenient. So that was the outcome in this study. But I think in most of our practice, we are following the once a dose 65 or 70 gray over a period of 6.5 to 7 weeks time. So I would stop here my talk, which was about abstract for the lung cancer. And